Welcome to our webinar. I'm Dimitrios Goulis, the current president of the European Menopause and Andropause Society, the EMAS, and together with the immediate past president, Professor Cano, and the board member, Dr. Antonina Smetnik, we will be your hosts in this EMAS Top 10 webinar. During the previous year, the EMAS organized a series of popular webinars and published several position statements and guidelines regarding the care of aging women and men. In this webinar, EMAS is proud to present its top 10. So within 60 minutes, you will have the opportunity to update yourself on the most important topics regarding menopause and andropause in an evidence-based and concise way. In addition, you can pose your questions in a live Q&A session. For your convenience, you can join either the morning session at 4 p.m. Beijing time or the afternoon session at 8 a.m. New York time. Both will be translated into Spanish, Mandarin, Russian, and Portuguese. So without further delay, let's proceed to our selections. Since many decades, several countries have included regulatory items for pregnant women in their legislation. The same is happening nowadays for breastfeeding women. On the other hand, very few things have been done for women in the perimenopausal period, particularly in their workplace. EMAS and its executive director, Professor Margaret Rees, took the initiative to put together a wealth of information and suggest a realistic solution for this very sensitive issue. Please visit the EMAS webpage on www.emasonline.org and locate the Menopause at the Workplace. You will find information such as the Global Consensus Recommendation on Menopause in the Workplace, an EMAS position statement. In 2020, there were 657 million women aged 45 to 59, many contributing to the workforce throughout their menopausal years. Although the average age of the natural menopause is 51, it can occur earlier, either naturally or induced by surgery, radiotherapy, and chemotherapy. While the menopause may cause no significant problems for some women, for others it is known to present considerable difficulties in both their personal and working lives. Workplace health and well-being frameworks and policies should therefore incorporate menopausal health as part of the wider context of gender and age equality and reproductive and post-reproductive health. You will also find a survey answering the question, does your organization have a menopause policy or guidance? Here are the current results. You can contribute to them. September 7 is World Menopause and Work Day. With the World Menopause and Work Day, we are trying to raise awareness on menopause in the workplace and fight for the reduction of the stigma and emotional burden attached to it. Menopause is a gender and age equality issue, and dealing with its consequences should be part of maintaining an inclusive work environment. Our ambition is to turn the date of September the 7th into a long-lasting platform to advocate and educate managers, supervisors, occupational health professionals, and the general workforce about the menopause. You will read the menopause on the workplace, so building evidence, changing workplaces, supporting women. It's an editorial published in Maturitas. You will also have access to the EMAS Menopause and Work Charter. The Menopause and Work Charter is an initiative of the EMAS to promote the recognition and consideration of menopausal health in the workplace as part of broader frameworks and policies on wellness, gender and age equality in the corporate culture. You can also download the Menopause at a Glance, our iconographics, to illustrate the 2021 EMAS Global Recommendation on Menopause in the Workplace. In addition, you can read several press releases and media coverage to be informed and communicate it with your patients. You can also download the Menopause Essentials 2021, a general leaflet on menopause, its symptoms, and its effects on the workplace and in private life. You will have permission to use the Menopause in the Workplace self-assessment tool. This self-assessment tool is a resource for employers and managers to move towards a more menopause-friendly workplace. You will be informed about population statistics, so recommended resources, web pages for statistics on menopause in the workplace, and you will read the written evidence from Professor Kathleen Riak on behalf of the International Menopause and Work Consortium to the UK Parliament. You can watch then on demand the whole Menopause and Work webinar series. It's a series of 3 webinars on menopause in the workplace, which took place on September the 7th, 2021, during the 13th European Congress and Menopause and Andropause Society. You will find updated evidence about research on menopause in the workplace, so research updates from 2015 to present. And finally, you will gain access to recommendation by non-EMAS organization, so guidelines from healthcare societies, personnel, and support organizations. So do not miss the opportunity to visit the EMAS website and acquire this evidence-based material for you and your patients. Menstrual disturbances are quite common in premenopausal women. Combined oral contraceptives are a justifiable treatment given that the correct diagnosis had been set. But what about bone health? What is the effect of combined oral contraceptives on both strength? Professor Antonio Cano has some answers for you.
The topic I am going to present is important for the management of perimenopausal women because they often suffer of menstrual disturbances, and at the same time there is a doubt of whether oral contraceptives, which many of them are using when they face perimenopause, is a good option in terms of bone preservation. And for that, I will initiate by presenting data from the study of women's health across the nation, in which you see that 2,336 women were followed for a series of years. And here on the left, you see which is the profile of the hormones, different hormones, FSH, estradiol, testosterone, and SHBG that they have, and which is the impact of the level of hormones at the level of lumbar bone mineral density. You see here, for example, that the higher the level of FSH, the lower the BMD, and also probably translating that low estrogens are detrimental for bone mineral density, as we all know. Here, the confirmation that lower levels of estrogens are associated with lower levels of bone mineral density at the spine. And here on the right, you see how those women suffering from menstrual disturbances still have some estrogen, but lower than women that preserve ovulation, as shown in here clearly. So those women most probably will suffer of this problem of low mineral density. Now, the question is whether oral contraceptives may be a good or not such a good idea. And for that, we have to differentiate between contraceptives that only have progesterone, and this is the case of, for example, of the medroxyprogesterone in acetate, in which you see that women using that product. This is a study in which some 4,000 women were compared with a similar number of women who were not users of the medroxyprogesterone acetate. And those users had an increased risk of 1.72 in what refers to the older women, those who were living the late reproductive years, very close to the perimenopause, and even higher, 3.04, in those women who were younger than 30 years. So only progesterone is not a good idea. But what about those women using estrogen, which is usually ethinyl estradiol, as we all know? Well, in that case, the state of things are not as clear as that. You see that this is a very small study in which only 12 women were using combined hormonal contraceptive, including ethinyl estradiol, and were compared with 37 women. There is a small decrease at the level of lumbar spine, femoral neck, and total hip in what refers to BMD, but still is a very small study. That's why up to date, what we know is, for example, which is the position of the European Menopause and Andropause Society, which was released clearly in this EMAS position statement, in which it was stated that combined hormonal contraceptives, including ethinyl estradiol, are a good option for facing the menstrual disturbances and also the bone-associated changes that these women suffer when they are lower, they have low levels of estrogens. Still, probably is not the best option because we know that estradiol is probably better, and a sequential product, including estradiol, might be a better option. But still, as I say, oral contraceptives, including ethinyl estradiol, may be an acceptable option for managing those cases. Many thanks for your attention.
According to the woman's characteristics and local availability, several options for menopausal hormone therapy exist. Breast cancer is a primary fear for women taking MHT. We know that all MHT regimens are not the same in terms of breast safety. So, which is the best? Dr. Antonina Smetnik has gathered some evidence that she will discuss with you.
Dear colleagues, I would like to thank the European Menopause and Andropause Society for the opportunity to participate in this webinar. Breasts are the target organs for numerous hormones and growth factors, and in the early 2000s, there was a huge decrease in the numbers of menopausal hormone therapy users because of the first results of the WHI study, which showed that combined menopausal hormone therapy increases the risk of breast cancer. The relative risk of breast cancer in users of conjugated equine estrogens and medroxyprogesterone acetate was 1.26. It is less than one additional case per 1,000 of women using MHT per year. However, there was a decreased risk of breast cancer in estrogen monotherapy users after hysterectomy, and there was no elevated risk in MHT prior non-users. According to the French E3N cohort study and registry study from Finland, estrogen and progesterone or estrogen and androgesterone were not associated with a significantly increased risk of breast cancer. According to the nested case control studies, with more than 98,000 of cases and 457,000 of controls, there was no increased risk from short-term use up to 5 years of estrogen only or estradiol dihydrogesterone and tibolone. Most women took combined HRT, which was linked to a small increase in risk of breast cancer. The risk increased with a woman's age, with lower increases in risk for women in their 50s compared with those in their 60s and 70s. The duration of treatment, with lower increases in risk with HRT taken short-term, less than 5 years, than long-term, more than 5 years. Current or more recent HRT treatment, which came with higher risks than past use more than 5 years ago. The type of progestogen in combined HRT with highest risks were seen with noritestosterone and the lowest with dihydrogesterone. The researchers stressed that some women who had never taken HRT would still get breast cancer. For example, if a group of 10,000 women in their 50s had never taken HRT, 26 women would still get breast cancer in a year. HRT is linked to 9 extra cases of breast cancer in a year, that is less than 1 in 1,000 women. The increased risk was mostly linked to combined HRT, and the type of progestogen made a difference. For women in their 50s, no extra risk of breast cancer was seen with combined HRT that was stopped more than 5 years previously. The extra risk among women in their 60s and 70s was minimal. There was no increased risk of breast cancer with any current HRT taken for 1 year or less. With past use of estrogen-only HRT, even if taken long-term. With past use of combined HRT taken short-term. Different types of combined HRT had different risks. The lowest was with dihydrogesterone, which is not prescribed as often as other progestogens with higher risks, noritestosterone, medroxyprogesterone, and levonorgestrel. It is important that general practitioners discuss the benefits and risk of HRT with women troubled by symptoms of the menopause. HRT can have a dramatic effect on these symptoms, and this research suggests that risks of breast cancer are low. The results could guide the choice of HRT and the length of time women take it. I thank you for your attention.
Several guidelines and position statements have been written for menopause. Therefore, a comprehensive guide to summarize the treatment approach was much needed. The care pathway from the European Menopause and Andropause Society provides an updated approach for monitoring and guidance of women in midlife, focusing on those approaching the end of the reproductive life cycle, going through the menopausal transition, and beyond. This care pathway from the European Menopause and Andropause Society, the EMAS, provides an updated pathway for monitoring and guidance of women at midlife, focusing on those approaching the end of their reproductive life cycle, going through the menopausal transition, and beyond. The care pathway is written by professionals involved in women's health and provides a stepwise, individualized approach stratified according to needs, symptoms, and reproductive stage. Furthermore, the pathway provides details on screening for chronic diseases related to menopause and aging. Treatment options for climacteric symptoms range from menopausal hormone therapy to non-hormonal alternatives and lifestyle modifications. Therapy should be tailored to personal needs and wishes. The pathway aims to offer a holistic, balanced approach for monitoring middle-aged women, aiming to control health problems effectively and ensure healthy aging. The informative text is illustrated with figures and tables. In these figures, you can see the final menstrual period that defines the menopause. The average age at natural menopause is approximately 50.5 years, with a confidence interval from 50.2 to 50.8. Women with premature ovarian insufficiency experience ovarian senescence before the age of 40 years. Termination of menses at an age of more than 40 years, but under 45 years, is defined as early menopause. Lifestyle advice for the management of menopausal symptoms and for prevention of chronic disease associated with aging and the menopause is an essential core of treatment and can be summarized in this table. Finally, this is an updated table of menopausal hormone therapy regimes. So, this is a complete list of all issues discussed in this concise and informative paper. In summary, menopause, or the cessation of menstruation, is the inevitable result of normal ovarian aging due to the depletion of ovarian follicles occurring in the late 40s or early 50s. The decline in estrogen concentration is associated with menopausal symptoms, especially hot flashes and night sweats, sleep problems, mood imbalance, muscle and joint pain, and symptoms of vulvovaginal atrophy. Spontaneous or iatrogenic premature ovarian insufficiency or early menopause requires menopausal hormone treatment at least until the typical age of spontaneous menopause. Post-reproductive health is further affected by problems related to aging and menopause like osteoporosis, cardiovascular disease, and cognitive decline. The management of women transitioning to menopause should be individualized, considering their risk profile and their wishes and needs. So, as this paper can be downloaded for free, please do not miss the opportunity to read it. Perimenopausal women are at high risk for weight gain. During the decade from 45 to 55, women can easily gain 10 kilograms of weight. Their treatment approach is a challenging task. Professor Antonio Cano will guide us on what to do and what to avoid.
The topic of this presentation will be the management of overweight at menopause, something which is important not only because of aesthetic reasons, but also because it has important metabolic implications. And for that, what we will do is to set 4 principal points. Firstly, we will comment about the prevalence and how the increase in fat is clear around menopause. Then we will present the hormonal background and then immediately the impact of hormone replacement therapy. Finally, we will comment about complementary options, and particularly the role of diet, and in this case, Mediterranean diet. I will start with this slide in which women from the SWAN study, the study of the women across the nation, were investigated about the hormonal background, but also about the body composition, and for that it was used a dual X-ray absorptiometry. And you see here that in comparison with the point 0, which is that of menopause, there is an increase here in the fat mass, which starts some years before menopause, but immediately when menopause is approaching, there is an increase in the slope of the accumulation of fat, which ends up in the global increase in fat, which is much more than it was before, but also which accumulates in the abdominal area, something that has important metabolic implications. There is a background of hormones, and in a special case of menopause, we know that there is a decline in the production of estrogens, but there is not such a change in the production of androgens. So the result is a high androgen-estrogen ratio, which is associated with an increase in visceral obesity. This has been well proved also in several experimental models. The increase in central obesity is associated with an increase in the resistance to insulin, which is then associated with the other features of metabolic syndrome, as dysglycemia, as shown in this slide, dyslipidemia, and increased blood pressure. But this is not the only reason for the increase and for the changes at menopause. And we know that because women who are treated with menopausal hormone therapy improve the situation created by menopause, but they don't sort out all the problem. This is clearly shown in this slide here, which is data from the HOPE study, in which some hundreds of women, as shown in the slide, were randomized to different combinations of hormone therapy or placebo. You see here that there are different differences in the response to those combinations. This is the change in mean body weight, but all of them were different to those receiving placebo. So there is some effect of hormone therapy, but still this is not the effect. So something else is needed, and this is why the approach of, for example, physical exercise or diet may be important. And I want to present you some data about the impact of Mediterranean diet in the metabolic syndrome. This is a meta-analysis in which here you see the incidence of metabolic syndrome as a result of the evaluation of case control and prospective studies. This is the global result in which you see that there is a reduction of about 27% approximately in the incidence of metabolic syndrome. And also important because of the interest of waist circumference. Also, you see that those studies which were assessing the impact of on waist circumference, there is a reduction here of around 18% in the perimeter of the waist of those ladies. So in conclusion, is something which is very prevalent, which has metabolic implications, and which may be improved with hormone therapy, but which requires often the contribution of other variables, like, for example, the case of Mediterranean diet, but also many others like exercise that I have commented, and in case of need, also some others like drugs or something else. Many thanks for your attention.
The start and duration of menopausal hormonal treatment have been a subject of a long-term debate. Nowadays, we understand that there is a window of opportunity. Dr. Antonina Smetnik will provide the necessary evidence to make the right treatment decisions.
Dear colleagues, I would like to thank the European Menopause and Andropause Society once again for the opportunity to take part in this webinar. Vasomotor symptoms are the early signs of covered risks of cardiovascular events like stroke and myocardial infarction, osteoporotic fractures, and cognitive decline. MHT started less than 10 years of postmenopause decreased the all-cause mortality by 30% and coronary heart disease as compared to placebo or absent of treatment. According to the American Heart Association scientific statement in 2021, menopausal transition is a time of accelerating cardiovascular disease risk. Menopausal hormone therapy, initiated in women younger than 60 or within 10 years after menopause, is currently the sole intervention that decreases the risk of cardiovascular disease and diabetes in healthy women at midlife. According to the EMAS clinical guide in 2018, MHT has a favorable effect on glucose homeostasis in women with and in women without diabetes. Timely start of MHT may delay development of type 2 diabetes. Oral MHT administration is preferable except for absolute contraindication. Among available and well-studied progestogens used as part of oral MHT, progesterone and dydrogesterone are the progestogens of choice. According to the publication Timing and Dosage of and Adherence to Hormonal Replacement Therapy and Fracture Risk in Women with Menopausal Syndrome, current and past use of MHT protects against bone fracture. The protective effect is dose-dependent, increases with cumulative daily dose and adherence, and initiation of MHT at the onset of menopausal symptoms demonstrates a higher fracture protective effect. MHT may prevent collagen loss, may improve water retention capacity, and increases skin thickness. Gradual loss of ovarian function is one of the factors contributing to the development of sexual dysfunction in women. There is a real relationship between the worsening of sexual function and the +10 reproductive aging stage the woman is in. Use of combined estradiol and dydrogesterone MHT in perimenopausal women has a positive effect on sexual function. Observational data suggests that younger age of fewer years since menopause may be associated with positive effects of MHT, whereas commencement of MHT in later years is associated with an increased risk of dementia. Functional MRI data suggests that there is improved efficiency of brain function during a sustained attention task in postmenopausal women receiving estradiol. Surgical menopause or early menopause increases the risk of Alzheimer's disease by 70%. If MHT commences before the age of 50, that risk is removed. MHT may correct the memory deficit directly, but the improved cognition may be due to the improvement in other symptoms that are synergistic in exacerbating the memory loss, such as sleep deprivation and hot flashes. And also, according to the Netherlands cohort study, timely MHT start before 50 years is an important longevity factor. I thank you for your attention.
The major, if not the only reason to include a progestogen in a menopausal hormone treatment is to avoid endometrial hyperplasia. As in all therapeutic decisions, what, how much, for how long, and by which route is of the essence. Professor Antonio Cano will update us on the available options.
The use of progestogens is an important topic, not only because we need progestins for the protection of endometrium, but also because they have important metabolic implications. This is why I will present you in just 4 slides, which are the main aspects related with the use of progestogens. And for that, I will go to the past, to the initial publications of Roger King and Malcolm Whitehead, which with endometrial explants were evaluating the impact of estradiol as compared with different progestins. You see here that norethindrone, norgestrel, MPA, dydrogesterone, and progesterone were compared in a technique which was used, the epithelial leveling index, which was a measure of the endometrial proliferations. And you see that with different days of treatment, norethindrone, levonorgestrel also, the case of MPA, the case of dydrogesterone, and also the case of progesterone, they all were enough to control the proliferation. This is important because progestins differ not only in potency, which is something which is shown here, but also in the metabolic impact. And this is important as shown in this slide. We know that there are progesterone receptors across the body, and they not only include the nuclear receptors, but also membrane receptors. This is why there are some actions, like for example, the action at the level of the central nervous system. You see here the positive modulation of the neural GABA4 receptor, and also the impact at the level of anxiety, depression, anesthetic impacts, and also, for example, at the level of the sleep. And it is important to compare one with the other concerning progesterone in terms of the general behavior. And also importantly, in the case of the oncology impact. I have brought you here the study of Vinogradova, in which different progestins were compared concerning the risk of breast cancer. And you see medroxyprogesterone, levonorgestrel, noreltestrone, and dydrogesterone. And there are many important differences. While there was almost no increase in the case of estradiol, there are differences in the case of medroxyprogesterone, for example, which showed an increase when it was used for a number of years, levonorgestrel, which was very parallel, and also noreltestrone. But look here how different is dydrogesterone, showing that the progestin is important not only metabolically, as we were commenting, but also from the point of view of any oncological impact. And it is important, and this is the last slide which connects with the first one, because we said that the progestin, if given for sufficient time, as shown by King and Whitehead, was enough to control endometrial proliferation. You see here in the Renis study, in which the incidence of hyperplasia, proliferative endometrium, of endometrial polyps, when comparing 1 milligram estradiol plus 100 milligrams micronized progesterone with placebo, there were no differences between them. So to conclude, progestins are important. Progestins don't need to be tremendously potent to control the endometrial proliferation, but need to be very well selected when considering metabolic and also aspects related with the oncological risk.
To provide the best care for women during menopause and beyond, health professionals must have received appropriate training. Nevertheless, the pregraduate and postgraduate medical curriculum regarding menopause seems very limited. The menopause, or the cessation of menstruation, is a stage of the life cycle which will occur in all women. Managing perimenopausal and postmenopausal health is a key issue for all areas of healthcare, not just gynecology. So the aim of this paper was to provide recommendation for the curriculum of education programs for healthcare professionals worldwide so that all can receive high-quality training on menopause. In 2014, EMAS published guidance on the essential issues that medical students worldwide need to know about reproductive aging, menopause, and postmenopausal health. This 2022 curriculum takes into account the 2014 recommendation, new research, and new treatment modalities, and is applicable for healthcare education at all levels, including undergraduate, postgraduate, and even specialist training. The informative text is illustrated with figures and tables. In this figure, you can see a quick guide to key menopause terms useful for pregraduate education mainly. And these figures illustrate a menopause curriculum for healthcare professionals. In summary, managing menopausal and postmenopausal health is a key issue for all areas of healthcare. Women should have access to accurate information and be able to seek advice on how to optimize the management of their natural or induced menopause and the years beyond. Some people require additional attention with involvement of specialist services. This includes women with chronic disease, premature ovarian insufficiency, or early menopause, or pre-existing disability, as well as transgender and gender non-conforming people. Healthcare professionals should provide an evidence-based approach for assessment and management and refer to specialist services as required. You will find all this information in this paper. This position statement has been already endorsed by the British Menopause Society, the EPCOC, that is the European Board and College of Obstetrics and Gynecology, the European Society of Endocrinology, the FLACSIM, which the Federación Latinoamericana de Societies de Climacterio y Menopausia, and the Society of Occupational Medicine. The paper can be downloaded for free, so do not miss the opportunity to read it. Among its other benefits, menopausal hormonal treatment can favor bone health, although it's not indicated for this purpose. Professor Antonio Cano will discuss how MHT can complement the treatment of postmenopausal osteoporosis.
The use of menopausal hormone therapy in the treatment of osteoporosis is gaining interest because when given in the moment or the interval in which we are promoting, which is the years after menopause, the 10 years after menopause, which is around 60 years, up to 60 years, not only produces benefits on the bone, but also at other territories. Thus, we are promoting this option because it is efficacious, as I will show you, and also because it provides other benefits. It is efficacious, as shown in this slide, which comes from the WHI, that you will remember is a randomized trial, was a randomized trial in which some 16 women were randomized to either estrogen plus progestin or placebo, because the result, as shown in this slide for the vertebral fracture, was a reduction of around 35%. In the case of total fracture, around 24%. This is something which was found for the wrist and for the hip, which are particularly difficult territories. But not only so, also because, as shown in these other slides, there is no rebound effect. So this benefit is maintained for longer. This is the follow-up of women who completed the trial and were followed for a number of years. You see here how the two arms of the study, that receiving placebo and the other receiving the combined estrogen plus progestogen, gave a similar result, that there is no difference between them. There is not a decline in the benefit of those who receive the combination of hormones. And the same was obtained in the other group of women who were randomized to placebo or only estrogens that I have not commented, but the result was very similar. And this has been confirmed in a meta-analysis like this one, reviewing 28 studies in which you see that for all fracture risk, menopausal hormone therapy achieve a benefit of a 26% reduction of all fractures. That's why scientific societies have produced guidelines positioning menopausal hormone therapy as a good option for the treatment of osteoporosis. You see here where is hormone therapy. In here, this is the case of non-vertebral fracture, which in which you see that the result for the benefit for hormone therapy is better than for vaseloxifene, for raloxifene, even for ivandronate, which is even worse than raloxifene or vaseloxifene. So finally, it is a very good option, and it is a good option not only because of that, but also because, as shown in this slide, which is the global result of menopausal hormone therapy in that window of opportunity between 50 and 60 years. You see two panels here in the upper panel, and the global result concerning women receiving the combined estrogens plus medroxyprogesterone acetate. You see in blue the benefit, and see the great benefit obtained for fractures, but also for death from any cause. This is something very, very important, also for diabetes and for other outcomes. And in red, the risk, an increased risk for breast cancer, for vein thrombosis, stroke, and coronary heart disease. The panorama is much better when considering only estrogens. And you see that you only have blue bars, only one red bar, which represents the risk for deep vein thrombosis, but we know that this is eliminated if we use transdermal estradiol. So in conclusion, it is an excellent option, not only because it is efficacious, but also because it provides a benefit which fits very well in the needs of women in this period of their lives between 50 and 60 years. Many thanks.
Cardiovascular disease is of major concern in women entering menopause. Although the administration of menopausal hormonal treatment should be considered individually, it may reduce cardiovascular morbidity and mortality if commenced during the early postmenopausal period. Let's discuss the evidence. Cardiovascular disease is of major concern in women entering menopause. The changing hormonal milieu predisposes them to increased cardiovascular disease risk due to a constellation of risk factors such as visceral obesity, atherogenic dyslipidemia, dysregulation in glucose homeostasis, non-alcoholic fatty liver disease, and arterial hypertension. However, an independent association of menopause per se with increased risk of cardiovascular disease events has only been proven for early menopause, that is less than 45 years. Menopausal hormone therapy, the MHT, ameliorates most of the cardiovascular disease risk factors mentioned above. Transdermal estrogens are the preferable regime since they do not increase triglyceride concentration and they are not associated with increased risk of venous thromboembolic events. Although administration of MHT should be considered on an individual basis, it may reduce cardiovascular disease mortality and morbidity if commenced during the early postmenopausal period, that is, less than 60 years or within 10 years since the last menstrual period. In women with premature ovarian insufficiency, the MHT should be administered at least until the average age of menopause, that is 50 to 52 years. MHT is contraindicated in women with history of venous thromboembolic events and is not currently recommended for the sole purpose of cardiovascular disease prevention. The risk of breast cancer associated with MHT is generally low and is mainly conferred by the progestogen. Micronized progesterone and dydrogesterone are associated with lower risk compared to other progestogens. So this informative test is illustrated with figures and tables. In this table, you can see an overview of the effect of menopausal hormone therapy on cardiovascular risk. As you can see, menopausal hormone therapy, especially the transdermal route, has favorable effects on lipid profile, glucose homeostasis, and visceral adiposity. The window of opportunity must be always considered. Menopausal hormone therapy may reduce cardiovascular disease, morbidity, and mortality if commenced during the early postmenopausal period, less than 60 years or within 10 years since the final menstrual period. Today, we already discussed other important topics such as the risk of breast cancer, which is minimized with the use of micronized progesterone or dydrogesterone. These figures illustrate an algorithm of cardiovascular risk assessment and personalized intervention in postmenopausal women. Estrogen-based treatment is indicated for women with bothersome menopausal symptoms within 10 years of their final menstrual period or to women with premature ovarian insufficiency or early menopause. In conclusion, transition to menopause predisposes the women to increased cardiovascular disease due to visceral obesity and dysregulation in hormone homeostasis, non-alcoholic fatty liver disease, and hypertension. However, whether menopause per se is associated with a higher risk of cardiovascular events has not been proven. On the other hand, both early menopause and premature ovarian failure are associated with increased cardiovascular morbidity and mortality, mainly attributed to ischemic heart disease. Menopausal hormone therapy ameliorates most of the traditional cardiovascular risk factors with different effects depending on the type, dose, route of administration, and type of progestogen. Menopausal hormone therapy may reduce the risk of cardiovascular events if prescribed within 10 years since the final menstrual period or in postmenopausal women less than 60 years old and at low or moderate cardiovascular risk. However, menopausal hormone therapy should currently not be prescribed for the sole purpose of cardiovascular disease prevention. In any case, there is a need for well-designed, randomized controlled trials with the newer regimes such as transdermal estrogen and micronized progesterone to prove their efficacy and safety in terms of cardiovascular and breast cancer risk. This concludes our presentations. I hope you enjoyed our top 10 selection. Professor Cano, Dr. Smetnik, and I will be more than happy to address your questions, which can be posed through the Q&A widget of your Zoom panel. So we are now during our live session, and as I said, Professor Cano, Dr. Smetnik, and I will be more than happy to deal with your question. Tonya and Antonio, thank you very much for being with us, as well as our hundreds of participants, and as I can see here.
Hi.
Hello.
I don't know if to say good morning or what, depending on where everybody is
Good
located.
afternoon, or yes, it's a complicated word, but thanks to technology, we can join all the world today, Antonio, from Beijing up to New York. Excellent. So I can see some question. One is from Elena. Is it possible to use Dynogest as a part of MHT combined with estrogen in women with endometriosis? Well, Elena, the key concerns about the use of MHT in women with endometriosis are reactivation of the disease or production of new implants. There is always a small risk for potential malignant transformation. So the data are not very limited, but some women are very limited, but some women do need MHT despite their endometriosis. It may be safer to give either continuous combined estrogen progesterone therapy or Tibolon, and you have to do this in both hysterectomized and non-hysterectomized women. This is one exception. We do not use progesterone in hysterectomized women, but endometriosis may be an exception, continue to give progesterone because, once again, of the possible fear of reactivation. There is a lack of high-quality studies, but of course, these are combinations that you can use in order to help these ladies. Any other questions? In patients with metabolic syndrome and cardiovascular risk, so the usual age group of 50 and 60, can they be started on low transdermal estrogen and micronized progesterone if alternatives are not effective? Antonio, would you like to answer this question?
Yes, of course. This is a very important and interesting question because obviously we have often this type of ladies and we feel a little bit as if we had not enough possibilities in our hand. But this is not the case because as I was commenting, the action of hormones in this context would be to reduce the insulin resistance and therefore to ameliorate the metabolic syndrome. But even more, if we are using transdermal estradiol and natural micronized progesterone, this is much, much better, because we know that progestins are different between them depending on whether they may have some affinity for other receptors in addition to the progesterone receptor. I'm thinking of the glucocorticoid receptor or the mineralocorticoid receptor, which is the case of some progestins which are quite often used. This is not the case of natural progesterone. So this might be an ideal option for treating these women and for providing benefits in terms of the evolution of their metabolic syndrome. So very good question, and fortunately we have a good answer for that.
Thank you very much, Antonio. Ellen asks where we may obtain the full version of paper concerning criteria of eligibility of MHT. I'm not sure what you are referring, Elena, the full version of the paper. You can send an additional query, actually, if we have referred to this paper during our presentation. What I can say is that if you are a member of EMAS, we have, please refer to the EMAS care online. It's a concise but rather extensive, about 100 pages document, so you can find all the necessary material concerning menopause and MHT. It's for health professionals, it's concise, it's updated, so I'm referring you to this. You can always have it through our website. Another question, maybe Tonya can answer it. It's from Manju Navani. Can transdermal estrogen, where norethisterone, both in a combined patch, be given to menopausal women who are diabetic and have hyperlipidemia, as transdermal norethisterone is insulin neutral and will not decrease triglycerides and will reduce lipids? So, Tonya, it's a question about if a woman has metabolic syndrome, hyperlipidemia, diabetes, if still MHT can be used.
Well, I think it's a question for Professor Antonio Cano for his brilliant presentation. Unfortunately, in our country, we have no transdermal norethisterone, and we have we don't use it. Speaking about women with metabolic syndrome, menopausal metabolic syndrome, if we understand that oral menopausal hormone therapy, for example, with dydrogesterone, can have some benefits in terms of glucose metabolism and lipid metabolism. And if a woman has no contraindications for menopausal hormone therapy, for example, it's just obesity and no hypertriglyceridemia or no elevated risk of cardiovascular disease. In this case, we prescribe estradiol with dydrogesterone in our country. But of course, if we speak about triglyceridemia or high, in this case, we try to use transdermal estrogens with micronized progesterone or dydrogesterone. And if we speak about high risk of cardiovascular disease, we try to avoid menopausal hormone therapy. But I would like to ask if it's possible, Professor Antonio Cano, to comment this topic.
Of course, he is the expert on this among most other issues. Antonio, would you like to add something to Tonia's answer?
Yeah, because the thermal prevents from metabolic impact at the level of the liver. That's why I think it is very interesting, as I said. And actually, we published a study several years ago of some 500 this combination, and this was absolutely neutral. So there was LDL, which was increased, but no triglyceride.
Mm-hmm. I can see, thank you very much, Antonio. I can see another question about, thank you for this excellent summary. Thank you very much. I would like to know about MHT for patients with autoimmune diseases. It's about spondylitis. I have to say that the evidence is not very good. Systemic lupus erythematosus is, let's say, a template for other autoimmune diseases. It is true that the efficacy and safety of combined MHT in selected patients with lupus has been studied in randomized studies. It's a difficult situation for sure. So I would say that MHT should be reserved for the management of severe and disabling vasomotor menopausal symptoms, preferably in women with stable or inactive disease and negative antiphospholipid antibodies. In patients with positive antibodies, the use of MHT should be carefully weighted against the thrombotic and cardiovascular risk. So yes, you can do it in case of severe problems, but you have to do it with all the necessary concerns, actually. I think we have asked the questions about dyslipidemia. Is it always necessary to prescribe anticoagulants such as aspirin to prevent thrombotic events? I don't know if Antonio is still with us, or Tony, if you'd like to add to this. I would say that for sure, no. Actually, there are only very specific cases that you may use aspirin. Aspirin is not something that you have to regularly combine with HRT.
Please, Dimitrios, can you hear me? Yes?
Yes, we can hear you now, Antonio.
Okay. Yes, I totally agree with you. I think we don't have any data supporting the use of aspirin in association with HT to reduce risk deep thrombosis. So no doubt about that, because the incidence is so that the use of aspirin might involve more risk than benefit. That's an important message, I think. It should be clear.
Thank you very much, Antonio. And we have a slight problem with your answer, your previous answer. Could you just very briefly repeat your answer about transdermal estrogen and norethisterone? Short summary, maybe.
Yes.
Please. Yeah.
Yes, as I was commenting a study we published in Archives of Gynecology and Obstetrics of some 500 women using this combination and had an actually small increase in HDL well received. So no problem. This transdermal combination of estradiol plus norethisterone acetate, both transdermal.
We have another question. In UK, we use 2 risk scores and not the traditional European score for cardiovascular disease. Therefore, at what levels do we do not give HRT? Once again, there are no, absolute values, as this is always true in medicine. Am I right? The rule of thumb is that as far as you have low cardiovascular risk, you can calculate it with any score. You can try everything as far as no other contraindication are there. If you are on the intermediate risk, then you can use preferably the transdermal route. If you are at the high risk, you may avoid HRT and go for other alternative issues, unless you believe that you can weigh the risk against the benefit. Antonio, I'm not very familiar with the Q-score, and it would be a good idea to try to answer questions concerning MHT, not only according to the cardiovascular assessment provided by SCORE, but by other cardiovascular score as well, such as the Q-score. Would you have any comments on this? Most probably, Professor Cano is not with us. Okay, I think we have answered all questions. It was very nice to have you with us. I don't know if I can share my screen. I think I can. So I'd like to take advantage of our last minute today, this morning. Please remember that we will repeat this session in the afternoon. So please, you are very welcome to visit the EMAS site. You are going to find excellent information about everything we have discussed here. Don't miss the opportunity as well to go to the site of the 14th European Congress of Menopause and Andropause. It's virtually a world congress that will take place between 3 and 5 of May 2023 in Florence. And I have a last minute actually notice from our editor-in-chief, Irene Lambrinoudaki, Matsuritas, saying that the abstracts of the previous Congress, of the 13th European Congress of Menopause and Andropause, are available from today in the site of Matsuritas, so you can visit them. Tonya, possibly a last word from you as we are concluding our session.
Dear Professor Dimitrios Goulis, dear Professor Antonina Cano, I would like to give a big thank you from all doctors, not only from Russia, but also from the Commonwealth independent states who are actively taking part in our webinar, and there were some questions from them, and big thank you for this opportunity to you and to the European Menopause and Andropause Society that we can take part in this very important events about menopause and well-being of women after 40 years of age. Thank you so much.
Thank you very much, Dr. Smetnik. Thank you very much, Professor Cano, and all of you for your participation. Once again, this event will be repeated. It's an afternoon session for Europe. I hope you liked this session. It was a new session for EMAS. It was not a traditional webinar, so we selected our top 10, let's say, trying to summarize your questions and provide the best evidence. And on the other hand, we have this live meeting at the end in order to pose live your questions. Thank you very much. Hope to see you again in one of the future events of European Menopause and Andropause Society. Bye-bye.
Thank you so much.
So good afternoon to all of you. Professor Cano, Dr. Smetnik, and myself, very happy to have more than 210 participants today. We are here in order to discuss your question in this last Q&A session of our webinar. We have a first question. It's a gynecological one, so most probably our gynecologist, Professor Cano, would be more suitable to answer it. And the question is, in a post-cesarean section, women that underwent hysterectomy plus bilateral salpingo-oophorectomy, when to start hormone replacement therapy. So if we want to start HRT in a woman that had cesarean section and bilateral salpingo-oophorectomy, how many time later can we start? Antonio?
Many thanks, Dimitrios. I understand that there is no issue concerning lactation, because this would be a little bit different. If it is not the case, and considering that postpartum is a period in which there is an increase in the risk of venous thrombosis, I would be cautious in initiating soon, immediate to the section. I say so because also these ladies are exposed to high levels of estrogens because of the placenta. So it will take most probably at least 2 weeks to start with a very clear hypoestrogenic clinic. Once it starts, I would certainly go firstly for transdermal estrogen, because we know that this is very neutral in what refers to the thrombotic risk. And since she has been subjected to hysterectomy, we don't need to add any progesterone. So transdermal estradiol will do the job. And this is something that we may, in this case, start as soon as the hypoestrogenic symptomatology initiates. If this lady is one of those lucky ones in which there is not much vasomotor symptoms, for example, well, we may still wait. And in that case, if we are not very pressed by the symptoms, we may still wait for something like 1 month, 1 month and a half, just to get rid of that prothrombotic risk associated with postpartum.
So very reasonable answers. You have clear answers. Prefer the transdermal route, and then we can wait, as you heard, from 2 weeks or to up to 1.5 months in order to be sure that everything is there. Antonio, you mentioned another interesting thing, this of breastfeeding. As far as I know, there are no conclusive research on the passage of HRT medication to breast milk, but anecdotally HRT has been used by nursing women without obvious impact on the infant or breast milk supply. So I would like to hear the approach of a very experienced gynecologist. What would be your thoughts about HRT and breastfeeding?
Well, in the case of breastfeeding, for any reason that is probably associated with the concatenation of endocrinological changes suffering by women who are lactating, and I am thinking of hyperprolactinemia, for example, there is not much symptoms in terms of vasomotor symptoms I'm thinking of. And as I saw, because you know that even in women who preserve their ovaries, in those cases, they are hypoestrogenic, but they don't have many symptoms. So again, if there is no symptoms, I would wait until they appear. And if it is the case, because obviously I must say that I am not aware, I haven't got any experience with ladies who have been subjected to double oophorectomy during a cesarean section. But in this case, in which the ovaries are not present, I cannot be sure that there is absolutely no symptomatology. So if symptomatology initiates, even if she is lactating, I would, in this case, it's very simple because we just have to go transdermal estradiol. So there is, in principle, no problem unless that interferes with lactation. This is something that needs also to be explored because you know that this is quite common, for example, in women who want to have contraception during lactation. And to be sure, they are prescribed only progestogens, which is something that does not interfere with the lactation. So the doses that we use in HRT are very low. I don't think they would interfere with lactation, but in case there is a problem in that regard, I would wait. I would withhold the treatments.
Thank you very much, Antonio, for sharing the thoughts with us. Two very difficult issues to deal with. So the cesarean section and breastfeeding, it's very difficult to find evidence in the literature. So it's so nice to have your wise full input in these cases. We have questions from the morning session and that I have to answer, and this is: what are the criteria for prescribing androgens in premenopause and postmenopausal women? What are the doses, which is the duration, which are the drug? Up to now, there is only one good meta-analysis saying that the main indication for prescribing androgens in postmenopausal women is because of hypofunctional sexual female condition. In this case, you may give testosterone, most preferably as a gel. As a rule of thumb, there is not much published evidence. You can give something like 1/10 of the dose that you usually, we usually supplement the male. So one dose, one puff of a gel, which is usually 10 milligrams of testosterone, 3 times weekly, something like this would be something that there is some evidence that you can use for the female sexual hypofunction. We have some other questions. Use of metformin in the postmenopausal women. Of course, we have no problem in prescribing metformin in these women, as far as there are no contraindications for prescribing metformin, as it's metabolized mainly by the kidney. We have to be sure that there is no degree of renal hypofunction, of renal failure. Antonio and Tonya, we are receiving some questions in Russian and in Spanish. Tonya, if you are kind enough, go to your Q&A if you find one of the Russian questions and try to translate and discuss it with us.
Of course, Dimitrios, thank you. Well, we have one question in Russian. It's about a patient she's 49 years old. She has no menstrual bleeding. She doesn't have any vasomotor symptoms, but she has some sleep disturbances, some emotional problems that reduces her quality of life. And doctor asks if we can prescribe this woman menopausal hormone therapy because this woman wants to have menstrual bleeding. What's your opinion? I think about sequential hormone therapy. Yeah. Well, if this woman is perimenopausal, of course, we can prescribe sequential menopausal hormone therapy, and she will have regular menstrual bleeding. She doesn't have any vasomotor symptoms, but we know that some symptoms can be associated with estrogen deficit beyond vasomotor symptoms, like sleep disturbances and some problems with mood swings and so on. And I think that in this very case, we can prescribe sequential menopausal hormone therapy for some period, and this woman will have some menstrual bleeding as well.
Thank you, Tonya. Antonio, could you help us with one of the questions in Spanish? Would you like to deal with one of them?
Yes, with pleasure. I have one here from Dr. Mechato Juarez. The question is something like when to initiate HRT in a patient after double oophorectomy in a non-puerperal state. So let's say in other cases. But usually the removal of the ovaries initiates symptoms in something like 7-10 days usually. So as soon as this lady is symptomatic, you may initiate the treatment with no problem. So I would say immediately that symptoms are already there.
Thank you very much. So you can see that there are many cases that you wouldn't consider MHT, but there is a real option there, and you can use it. This morning we discussed difficult cases like systemic lupus or epilepsy or other conditions. So if you know what you are doing, and if you read the EMAS position statements, you will be in a position to help your women that really need HRT. I think that this summarizes our afternoon session. Thank you very much for being with us. If I may share my my screen, let me do it. Just give me a moment to.
We have some more questions, Dimitrios, here.
I can see some here. I think we have answered the majority of them. Testosterone pellets, another question. This is not something that we do, especially for women giving pellets with all these problems, the difficulty in put them in place. You may have some complications. It's not easy to remove them. There is no much such experience. So concerning testosterone, once again, gel would be my preference rather than trying to do with deal with testosterone pellets. Let me show you this. Okay. I assume that you can see my my screen. Is this true?
Yes, we can, Dimitrios.
Oh, you can see. So don't miss the opportunity to visit the EMAS website. You will find then a wealth of information concerning guidelines and education, as you can see here. So please do it. This is the right time to say special thanks to our sponsor today, Abbott, with a simultaneous translation into Russian, Mandarin, Portuguese, and Spanish in this double session, make this webinar available all over the world. I'd like to share a note from the editor-in-chief of Maturitas, Professor Irene Lambrinoudaki, and this is about the previous European Congress of Menopause and Andropause. Professor Antonio Cano was the president, main organizer of this Congress, and we are pleased to announce that the Congress abstracts can be found and downloaded now from the Maturitas special issue. So don't miss the opportunity to read this as well. And of course, you have a big invitation for the next Congress, the 14th European Congress on Menopause and Andropause, that will take place from 3 to 5 of May in the beautiful Florence. So please consider it, being with us and discuss everything concerning menopause and andropause. Having said this, I'd like to cordially thank Professor Antonio Cano for his contribution to this double seminars today, as well as Dr. Antonina Smetnik. Both of them are doing tremendous job for the European Menopause and Andropause Society. Most of all, thank all of you very much for your kind attention. I really hope that we have the opportunity to see you again in another EMAS event. Thank you very much. Bye-bye.